think I know everybody in this room just about, but I'm Mark from the tertiary hemodialysis, and this is my clinical profile. Start off with a case. 56-year-old female, past medical history of hypertension, diabetes, presents to the ED with right-sided jaw pain and headache times 3 days. Her vital signs are fairly unremarkable, except for she's got like a low-grade fever. So what else do you guys want to know about her history or HPI?
Any recent dental procedures?
No recent dental procedures at all. No trauma. She doesn't have any blurry vision or visual changes.
Any proximal muscle weakness?
No. Just in general, she kind of has this like fairly, unremarkable HPI aside from this headache, this jaw pain. It kind of gets worse whenever with mastication, but otherwise you really can't tease out anything else.
Headache unilateral or what?
Sorry?
Is it unilateral headache or bilateral?
It's a unilateral headache on the right side. So, and you have this lady just staring at you while you're doing your HPI.
Are you mad?
So you do physical exam. So she's well hearing. All the cranial nerves are intact. Finger and nose is normal. Normal gauge. She doesn't have any signs of meningismus. You just note some tenderness over the right temporal area. So, ask this question. As far as which hallmark studies used to aid in the diagnosis of this disease in the emergency department? Yep, you're not going to do an LP, you don't want a CT, you want an MRI, you're going to do PSR. So, I don't know if everybody saw the title of my PowerPoint when I was trying to load it, but I'm doing my talk on temporal arteritis. So the objectives are to kind of just recognize the clinical presentation, understand some critical elements used in the diagnosis of this disease, mostly for the emergency department, just because it has a very serious complication that could be prevented under our care, and learn about the correct management from the emergency department perspective. So it is a vasculitis of large and medium-sized vessels. So basically you get like some type of initial factor that initiates an immune response. You get antibodies kind of attacking the endothelium, and then you get immune complexes, which basically promotes inflammation within the vessel. And it's a systemic disease. It mostly involves cranial branches of the aorta. And the most serious complication is visual loss, and that's from ischemic optic neuritis. So clinical presentation. So this is our typical presentation. You can't have fever just because it's an autoimmune process and you get inflammation. You can get a headache, get some visual changes, as that's one of the serious complications is visual loss. You can have some scalp tenderness, specifically like over the temporal area. You get jaw claudication. So previously you see how the artery kind of runs along the jawline, and that's how you get the jaw claudication from the inflammation of the vessel. And then you get for artery tenderness. And then you can get some atypical presentations. I think these are more or less like case reports where it's like a patient had a primary complaint of dysarthria, mesenteric ischemia, pericarditis. I think these patients had like further workup and somehow they found out they had temporal arteritis. So the differential, you can have acute angle closure glaucoma, a migraine, TMJ, and post-orthopedic neuralgia. I think the most important one in this one is just because it's kind of, symptoms are like migraine, it's usually unilateral headache. You can have like a visual aura, which, so if you're not thinking about this could be like a really easy disease to miss. You don't have it in the back of your head. The epidemiology of it, so usually you don't think about it in patients younger than 50. It happens, I think it's twice more likely in women than men, and whites than non-whites as well. And it's associated with polymyalgia rheumatica. So usually if they have PMR, their chances of having giant cell arteritis is like 40 to 50%. However, vice versa, if you only have giant cell arteritis, your chances of having, and that's the only thing you have, to have PMR is like 15%. So any patients that have PMR history, you definitely want to think about this disease process going. And then the American College of Rheumatology, so they have this classification criteria for giant cell arteritis. And basically, the gold standard is to diagnose this disease is a biopsy of the temporal artery. And even then, this disease, it can have like patches of inflammation. And so it's not, sometimes you can have a negative biopsy, but still, have the disease present. So about 4 of the 5 of these we can detect in the ER. So age greater than 50 years old, a new onset of headache, temporal artery abnormalities. So basically this could be like scalp tenderness, it could be scalp enlargement, which if you have not scalp enlargement, temporal artery enlargement. And if you have the enlargement of that artery, you're 4 times more likely to have temporal arteritis. An ESR greater than 50, and then last one is, the gold standard diagnosis biopsy. So the management. So say you suspect it in the ER and you have like 4 of the 5 criteria. If they don't have any visual loss, you're going to start 40 to 60 milligrams of PO daily, give them the stat dose in the ER. If they do have like any type of visual loss, this is basically an automatic admission, and I would consult ophthalmology. If it's 8 to 5 on a Monday through Friday, I would also give rheumatology a call. But you have to give 1,000 milligrams of IV prednisolone, and they have to be admitted for continued therapy, which doesn't really matter for us after they're admitted, but it's you get that dose daily for about 3 days, and then they can be discharged from the patient. You also want to give them baby aspirin just to prevent maybe a thromboembolism. And as I said before, this is like the big reason why we have to look out for this in the emergency departments, because you can get visual loss, very serious complication of this disease. And of course, also in the middle of the night, I did ophthalmology. So summary. So basically, if I have like a female over 50 years old and they're white, I would definitely, with a unilateral headache and some of the clinical symptoms of a migraine, I'd be a little bit more suspicious of this disease, and I would go ahead and draw an ESR on her. And you can also do ESR. I know I talked a lot about ESR, but you also can have a CRP as well. We usually just draw them both, but CRP would also be elevated in this. But the American College of Rheumatology, they usually don't have ESR as the criteria for diagnosing this. And then basically, like with most autoimmune diseases, you treat steroids. So and get follow-up ASAP. I would probably just consult in the ER. And that's it. I don't have family, I don't have kids, so I just put some comics up. Awkward Yeti, that's some awesome medical comics. And then since I'm a distance runner, I put that one up too. And my references, and I didn't put a thank you slide, but Dr. Sterling helped me out with editing this PowerPoint. So, and that's all.
The ESR and the CRP being good, like rule out tests for temporal arteritis, because they're like very sensitive, but very poorly specific. So if you were trying to build a case that's not that you were concerned that somebody had temporal arteritis, and the ESR is a part of the criteria, but maybe not enough to diagnose it. What would the ophthalmologist or the rheumatologist really like ask for to like kind of convince them that this was temporal arteritis?
Well, that's
Biopsy,
usually,
of course.
yeah, aside from the biopsy, the ESR and the CRP, if you have like a it was like 4% of patients that had a positive biopsy had like a normal ESR and CRP. So I was reading that you could have like some, I didn't get too detailed into it, but like if you do a fundoscopic exam, that's probably what the ophthalmologist would do. Maybe they would see like some signs of damage. That's what I saw as far as that goes.
They're also trying to study ultrasound.
Yeah, so I didn't talk about that too much or at all, but yeah, there's some imaging modalities you can use, and ultrasound has been one of them. Kind of a duplex to check to see if there's blood flow in the temporal artery, or there's something called halo sign. But of course, with ultrasound, it's all user dependent to, you know, for as far as the specificity and the sensitivity of getting a diagnosis of these. Yes.
What is the time course, and is it a waxing and waning? Will the patient have like kind of blurry vision intermittently that resolves and then comes back, or is it just getting worse and worse and worse?
Well, usually with if you have like the ischemic optic neuritis, it is a bad thing, and like you can get a small amount of recovery from it, but once they start going downhill, it's really a matter of just kind of just stopping it and keeping it where it's at.
But specifically, like for our patients that come in and like, oh yeah, I get this blurry vision occasionally, it's bugging me, it's been going on for a couple months. Like we can say that that's not GCA, right? Because it would be getting worse and worse with inflammation.
It's an acute process.
It's an acute.
It's an acute process. So it's not gonna, you couldn't necessarily say that, but once you've had spasm of the artery and you're not getting appropriate blood vessels to the optic nerve, it's acute. It's just like the heart, right? So time is muscle and time is eye. That's why it's one of the, you know, very few necessarily, ophthalmologic emergencies. That is one thing. It's an acute process. And once you've embarked in that issue, you can't get back.
I just have one comment and one question kind of for the group. First, since we're kind of I think emergency medicine is the evidence-based medicine founders and pushers in medicine. By your second year, don't present Koenig-Brzezinski signs to me anymore. The sensitivity is terrible, so if you throw that in there, that's a medical student thing. I mean, we give you a pass because you're EMI and you're going to want those stuff, but I got 3 years to work on you, and I'll work with the statics and that stuff too.
Four.
Yeah. Oh yeah, I got 4 more.
Nice.
Yeah.
So yeah, kind of along that, I love this topic because ESR, like we get ESRs on so many different things, but this is it. I mean, this is really the only thing it's good for that's been shown that it's sensitive for. And you kind of mentioned you can throw in CRP, but we really don't know why we're throwing in CRP, right? Because if we studied it, it's ESR. And I don't know, I mean, orthopods like the ESR, but they also still tell us not to get Motrin for fracture, so you really can't trust them for that stuff. I don't know why, and I'm wondering if anybody here knows. My pediatrician always orders an ESR on my kids. Like my kid's like in the 0 percentile, he's always been that way. But they always like trying to find something with the ESR. And I don't know the pediatric literature, if there is any other reason why. I ask everybody this all the
They
time.
love CRP. I don't get it.
Yeah, they love CRP, I don't know why. So.
Yeah, I was just in
We
the
were just saying that,
NICU.
like, every time I work in peds and there's one of the PEM attendings there, they're getting CRPs on.
I don't know why.
Yeah, when I was in NICU, we got them all the time. It was like like a marker for like subtle sepsis or something. And then that would be a marker to start.
I think in the NICU setting there was a literature for that.
Yeah,
A few years ago, when kids had fever, I think nowadays you don't use that anymore. But a few years ago, that was one of the criteria. You send the CDC if it's more than 15,000. If the CRP is positive, you do blood culture, you give them Herceptin, and if the CRP is negative, you don't do it. We don't use those criteria anymore. But maybe 10 years ago, that was kind
we
of
would
the
trend
routine
CRP,
thing.
and that would
Do you
be
not
right
use
now.
them because they weren't good for sepsis and they're just extrapolating to what if I found something? Or was it ever real?
It was never real. It was just a common practice.
Yeah,
A lot of the old timers you know, with, including me sometimes, but would throw in an ESR on a patient where, to tell them if the patient is sick or not, right? You bring, not just a kid, but an adult comes in dealing with a chronic illness or something. If the ESR is high, we get very suspicious and go nuts with a lot of other tests, and if the ESR is low, it's nothing, you know. So when I was training, it was very common to throw in an ESR in the clinic patients.
But for kids, it was used for fever without the source.
Oh, yes.
So I have a kind of a difficult question. If we had a patient that we were concerned about for GCA, and let's say the SED rate is like 47, CRP is elevated, but they don't have any visual issues, opto clears that. Can we safely send them home? Can we arrange for biopsies for further confirmation? Like, how would we approach this kind of patient? Or would we just start them on prednisone and have them follow up?
You have to be careful with starting on prednisone because they don't like it because of the biopsy.
Right, but I think you still have like a couple of days,
So
but I
it
don't know how.
depends on, you know, honestly, I think, and the other attending can comment, but I would say my starting on prednisone is depending on how early I can get the biopsy and follow. So if I can get that like the next day or, you know, reasonably, then I probably wouldn't, knowing that I can get them in the next day, but if not, then I just start and care less about the biopsy.
But who do we contact to?
Yeah, I think you're gonna get a large, to answer your question, I think you're gonna get a big continuum of what attendants are gonna do. Personally, I am a big symptom person. That matters a lot to me more than the test. So if they're not having symptoms, I'm comfortable to answer your first question with that person going home. And then I think the contact is really crucial. Like, you don't necessarily have to guess whether to start on prednisone or whether or not, or when to follow up, if you actually get a hold of that ophthalmologist. So I'm kind of punting on your second question by saying, you know, you can pretty much anywhere in the country get a hold of some ophthalmologist at some time of the day and ask them, you know, follow up in a day or two, and what would you like you to start with?
Here, it's very hard to get a biopsy done by opto. I've tried, and usually it's a couple of weeks, week or two. If you're dead, it might be a week, but usually it's 2 weeks. And so you have to, again, use your judgment. If you're really concerned that this is temporal arteritis, and this, then I think you're obliged to start them on steroids. If your clinical really it isn't, but you would just covers, you know, doing CYA stuff, it's covering your butt, then you don't do it. But you can always send them to the ophthalmology clinic in a couple of days, or neuro clinic. Usually I wind up calling both ophthalmology and neuro. That's what I wind up doing from work.
Yes.
Quick question. I had a patient come in, basically had temporal arteritis, loss of vision, and she pulls out a pill bottle that says that she's already on prednisone for like 3 days. So all I found was like just give more steroids. I was wondering if you could ask like if there's other treatment, if there's kind of like a steroid failure of sorts.
And with the dose was
was
like
like
14, it's like 600.
So it's like
They were having vision loss.
or it's already too late, or
Right, if they have vision loss, it's like already too late, but yeah, I feel like if steroids don't work,
You know, it's like a low dose outpatient.
Yeah.
Which was admit with 1,000 milligrams of methadone.
yeah, it was kind of like you just give more.
Yeah, it's like.
right, you would continue it, but I would just stat off the
So
console.
she was giving it, she was giving it if I had an ophthalmologist, and said you might want to just take that. She was like, yeah, I still have symptoms.
Also,
Right, but
it's
the thing
rare,
is, it's
but-
like, it's not gonna, you know, like we were saying, it's not gonna, you know, because you already have the symptoms and the ischemia of the tissue. So, she's still having symptoms, but she's already on steroids. I mean, I wouldn't expect improvement or much improvement, if anything. Oh, yeah, sorry. Yeah.
I don't know if you mentioned it, but what's the actual incidence of this? I know it's one of those don't miss diagnoses, and so we're probably getting a lot of negative workups, but how often? actually confirmed?
Right, so, sorry, long answer short, or, I don't want to make up anything, but, I
I was just curious, because it's one
Right.
of those things that we're always talking about, but how often is it actually gonna happen?
sorry, did you have anything?
Oh, it's a different subject.
Oh,
Just
okay.
with Linda, what you were saying, it's a rare complication, but these patients can also have strokes. So imagine in a patient like that, if they have such severe disease that they're, losing function on steroids, I think that patient would have to be admitted.
And that's another thing, like just, I mentioned baby aspirins, yeah, don't forget the baby aspirins as well.
Just also to add on the differential list, when I see that, temporal headaches or frontal headaches, I always also think about sinusitis, which is actually.
Oh, right, that's a
common.
good one too. Thank you for that.
And multiple sclerosis.
MS, yeah, and it can be bilateral too as well. So even if it's unilateral vision loss, or if you have bilateral, I wouldn't dismiss it either. It's not. Okey-doke.